Hello, everyone. Welcome. Thank you so much for being here. I know it's Friday, and we don't have a lot of classes Friday, and the students don't want to be in school when they don't have a class, so we appreciate you being here. I appreciate my colleague, Mark Smith, to be here. I appreciate all of you, and Romeo, thank you so much for being here. Romeo is one of my students who started this whole awareness of HIV and AIDS in our classes. So this event is in collaboration with a wonderful panel, and we will introduce them, and the Student Club Long Beach LBCC Justice Scholars, a group of courageous students that started this movement in the past couple of years, and the Long Beach City Justice Scholars is a club that advocates for social justice and formerly incarcerated students. And we had amazing events this semester. This is our final event, and I believe that this is such an important, vital issue that everyone needs to be aware, especially for those of us in the field of, in the health field. But even if not in the health field, this is so important. The subject is very important to have an information, education, awareness, and advocacy for. So I thank all of you and our beautiful panel to be here. I would like to acknowledge a couple of the people who are involved with Justice Scholars. Tyler, who is taking a video right now, is the president of the Justice Scholars, and Jessica Martinez is a wonderful treasury secretary and multi-purpose person. And at this point, I would like to ask Jessica Martinez to come and read a short bio of our panel. Thanks.
Good morning, all. Good morning to our panelists. I want to thank you all for coming out on a Friday morning. But we sincerely thank you for your willingness to come out and just gain some knowledge, gain some wisdom. So I would like to introduce our panelists. First up, we have Mr. Nolan Ross Samuel. Nolan. At an early age, he became involved with HIV/AIDS prevention and education work through the Asian Pacific AIDS Intervention Team. Throughout his own journey, he has been heavily involved in community events surrounding the epidemic and stigma of HIV and AIDS. As a community organizer and advocate, he has organized several teams represented at AIDS Walk, LA, and OC, and has raised thousands of dollars for the cause. In 2012, he himself was diagnosed with AIDS and AIDS symptomatic disease and has become a survivor of a near-death experience, specifically related and unrelated HIV/AIDS diagnosis. Nolan's inspiring story includes not only the stigma related to HIV and AIDS, but a seemingly positive family dynamic, quickly turned into heavy shame, guilt, and abandonment that played a vital role in his codependent search for love. He just found it in all the wrong places. Experimenting with alcohol and drugs starting at an early age, he found himself hopeless and lost without support and/or positive community-based alternatives. The road to recovery has taught him that even he can rise up from being a victim of mental, physical, and spiritual ailment to becoming a survivor who has the passion, compassion, and empathy for a community that he holds dear to his heart. Nolan is dedicated to helping the community acquire the knowledge it takes to grow stronger with empathy in order to help those who are still suffering. He hopes to achieve this by being of service and sharing his story. Let's give Nolan a round of applause. Next up, we have Jalen Olens. A newcomer, the HIV field, with only working in HIV prevention for a couple of years. However, he has been working with LGBTQ individuals for over 7 years. He is passionate about making a difference in the lives of those he works with. Currently, he works as a health educator for the P-Power project at Cal State University Long Beach, working to increase HIV awareness and promote regular HIV testing with young Black men who have sex with men, both on college campuses and in the community. He hopes to continue working in the field and ultimately wants to reduce new infections amongst Black individuals in Los Angeles County. Next up, we have Mr. Michael Boutron. Michael has worked in HIV prevention, testing, and treatment for 25 years. At Cal State Long Beach, he participated in several research studies that were chosen by the CDC as evidence-based interventions and presented outcome data as international aids in Durban and Geneva. He has worked with health departments across the state of California, helping them to incorporate these interventions into their existing prevention efforts. He has also participated in studies of HIV-positive population at Cedars-Sinai and Harbor UCLA medical centers. More recently, he has worked with clients of the CARE Center and implemented opt-out HIV testing in the hospital's emergency room. Currently, he provides PrEP services at CARE. Boutron has also been involved in the community as a member of the Long Beach HIV planning body since its inception. He has also founded and facilitates a newly diagnosed HIV support group that has seen over 400 participants since its inception. We have Mr. Ismael, or better known as Ish. Ish has been working behavioral health services for most, if not all, his career. His background is in medicine as a part of an accelerated emergency medical technician project in 1997, where he learned medical triage and trauma care. From there, he participated in an accelerated medical assistant program, which would set the path to becoming a registered nurse. During his first assignment as a medical assistant, he worked with a physician whose patient base was monolingual, Spanish, speaking men who were recently diagnosed with HIV. In those sessions, he learned what barriers this key population was experiencing and felt a call to action to become part of the solution of ending HIV and AIDS in his community. In a career move in 2000, he became an executive assistant to the Director of Programs and Services for Bienestar, where he gained expertise and contacts within Los Angeles County Department of Public Health, learning about program development, funding opportunities, and standards of care. In 2004, he was headhunted by the Los Angeles LGBT Center to work on a partner non-fiction pilot program. Excuse me. Non-fiction, which is now the model used for linkage to care and partner services in most Los Angeles County HIV prevention programs. In 2008, as a result of these experiences, he moved to Long Beach and the LGBTQ Center of Long Beach, where the collective experience, knowledge, and contacts allowed him to establish a thriving HIV testing program, STI screening and treatment program, transgender health services, and HIV-positive support services for individuals impacted by HIV. Let's give him a round of applause. Last but not least, we have Mr. Tanu Ayu. The founder of Project Alofa, a civil rights nonprofit that advocates for the formerly incarcerated and Asian Pacific Islander LGBTQIA gender nonconforming communities. His passion for social justice and equity includes volunteer work with organizations whose intent is to transform the criminal justice system and advocate fair policy change for the formerly incarcerated. His vision of creating safe spaces for the LGBTQIA community resulted in the first Native Hawaiian Pacific Islander peer support group at the Long Beach LGBTQ Center and Pacifica Pride. He was a steering committee member of Building Healthy Communities Long Beach and now facilitates the Coalition for Safety and Justice with current work on diversion in Long Beach. Tanu is a huge advocate for PrEP and PEP and is grateful to speak on PrEP in the Native Hawaiian Pacific Islander communities. He is a program coordinator for Lakota Treatment Center in Long Beach, and he works as a court liaison and performs SUD screenings for clients in need of residential treatment from the court system. He is also an accomplished flute and saxophonist and actively plays with the Colburn Adult Symphonic Winds each summer. Let's give him a round of applause. Well, I'm out of breath. What talented men. Thank you for coming out, and thank you.
Thank you, Jessica. I need to mention that this morning, as soon as Jessica came to the room, I just gave her the papers and said, "Can you do this?" So thank you so much. One thing is that this session is being videotaped. I want everyone to know, and also it will be on Long Beach City College YouTube channel. So I will just leave it up to you how you want to do the panel. If you like to let the audience know when do you want the questions, the Q&A session, and I believe that Michael, you're moderating the panel. So thank you so much.
Hi, everyone. My name is Michael, and you've already heard my introduction. When Nolan approached me to do something here on campus, we had a conversation and talked kind of a little bit about where we are with HIV today. There's a conceptual model that we're using that's called the treatment cascade. And if you think about a bar graph where you have a large bar and descending smaller bars, that's kind of the conceptual model that we're using to address HIV going forward. And I feel that the panel, all of us included here, are a personification of what that treatment cascade is about. So to back it up a little bit, to give you a little bit of history, HIV's been around for a little over 35 years, something like that. We have about 70 million people have been infected. I don't have exact up-to-date numbers, but I'll give you ballparks today. So about 70 million people worldwide have been infected. About half of them are dead. We have different epidemics in different parts of the world affecting different populations, but I think it's safe to say that it's disproportionate wherever you go, and it just affects different disproportionate populations in different places. Here in the United States, it's like 1.3 million, something like that, who've been infected. Over the past 20 or 30 years, it's been about 40 to 50,000 people who've been infected every year, and that number's been pretty stable, which is not good, because we've been doing a lot of efforts to reduce the numbers of new infections. And in the early days, a lot of that was focused on behavioral interventions, getting people to do things like use condoms, not share injection equipment. One of the promotion campaigns is called ABC, Abstinence, Be Faithful, and Condoms. So we've pushed a lot of different behaviors, and we haven't seen the needle move. I think we're at an exciting time, because when Obama became president, they actually kind of took a step back and looked at the efforts and tried to address it in a new way that's more medically based. And so the idea is you have a certain number of people who are infected, Like I said, it's about 1.3 million in the United States. Here in Long Beach, it's about 6,000 people. And not everyone in that group knows that they have HIV. So there are people who might be at risk and get tested annually. There's people who don't think they're at risk and maybe they've never tested. But they're operating as if they are negative, because that's kind of the default for most people. They think of themselves as negative until told otherwise. And so that group of people who are infected and don't know they have it tend to be one of the drivers of the epidemic, and are creating a lot of the new cases of HIV. So in the model, the way you address this is you want to test everybody. If we can identify everyone who has it, we can get them into treatment. And they can make adjustments in their lives so they don't spread the virus. So that's the first step. So here in Long Beach, I've tried to do the calculation. I know nationally we're at about 15%, does that sound about right, who don't know that they're infected, and that number has actually gone down because of new initiatives to increase testing. So we've made some progress in that area in the past few years. Here in Long Beach, I've tried to do a calculation. It's a much smaller population, so the calculation I got was 16 to 24% who don't know that they're infected. So we're doing a little worse than the national numbers. And I can't narrow it down to a specific percentage just because we're dealing with a smaller number and there's a little bit of variance in the calculation. So that's something that we need to step up to. And so I think we're gonna hear from Ish, and we're gonna hear about what's been going on as far as testing here in Long Beach, because I think his is the premier program. That's where I send everyone to if they need a test. He's open in the evening. It's free. It's like if you want to have an ideal testing program, you're going to have no barriers, and we have that in Long Beach, which is a good thing. What's interesting too is we have a lot of a majority of people who find out they're positive are actually finding it out through their private physicians, and so we can actually do more in that area as well, getting more physicians to do regular testing. The next step in the treatment cascade would be linking people to care. And that's an important step, and that's where kind of the most improvement needs to be made. Right now, about half the people who test positive get into medical care. And there can be a lot of barriers that get in the way of getting somebody in front of a doctor and get lab work done and get medications and things like that. It can be social service issues. The things that I'm always thinking about are homelessness, drug use, mental illness, all those things, if they're not addressed, and it's going to make it really difficult for a person to get into care and to stay in care and to stay on top of the medication and what they need to do. So hopefully we'll be talking about that as well, what we're doing to address those issues here in Long Beach. And then once we get people in the door of the clinic, it actually works pretty well. I know in my clinic, the goal of therapy is to get somebody with a viral load, that's the measure of the amount of virus in their body, to a level that's undetectable by the current test. So when we get them to that level, which can, when they start on meds, it can take a few months, they'll get to that level. At that point, when they have an undetectable test, they're not going to be transmitting the virus. They don't have enough virus in their body to do that, and now the CDC has acknowledged that recently, and they've signed on to what's called the U equals U campaign, so undetectable equals untransmittable. So the idea is if we test everybody, identify the people who are positive, get them into care, and get them to undetectable, we can stop the spread of HIV. And we know that's not going to happen overnight, so we have programs like PrEP, which is taking a pill a day if you're in a risk group, and that pill will keep you negative. And so we have other tools in our tool belt, but it's a very different model that we have now that's much more medically based, doing HIV testing, doing medication for people and things like that, than the behavioral model. And we've seen in communities that have really championed this new model, places like San Francisco, New York State has made a really strong push to buy into this model and to promote it. Also, Washington State has done a really great job. in those areas, we've seen a decline in new infections. So we know it's working if there's the political will to get it done. So that's kind of an overview. And I just want to talk briefly about the CARE program and what we do there. One way that I like to think about HIV is that it affects different populations differently. And compared to a lot of other diseases that are chronic and manageable, like diabetes or high blood pressure, HIV is actually a fairly easy disease to manage. Once you're on the medication, for most folks, you're taking a pill a day. The medications are much easier to tolerate today with fewer side effects. You take your pill a day or your couple pills a day, whatever it is, and then you go to the doctor every 3 months for a checkup, and you get your prescriptions refilled, and you keep at it, and it's a disease that's more manageable than something like diabetes, where you have to do a lot of major lifestyle changes, change what you're eating, test yourself for glucose several times a day, take medication, maybe inject yourself with insulin. It's a disease that has to be managed from hour to hour. And so we have people who are doing well, who are high functioning, who have great insurance, and they take the pill a day and they do great. And I don't see them. Those aren't the people that I work with. So the people that I'm seeing in our clinic tend to be the people who are having those other issues that I talked about. So at the CARE clinic, we have programs, we have case managers, we have people who do benefits that enroll people in programs to pay for their meds and to pay for their medical visits, enrolling people in programs that meet their social service needs. We have our own housing office, we have our own food bank, we have our own dental clinic, we have in-house mental health staff, and we have referrals to programs that help people with addiction, and hopefully we'll hear about some of the services that can address that for people, and services, and we also have an in-house housing office that can help stabilize people's housing. So with all that kind of wraparound services, we can take the most vulnerable people with HIV and do better with them. So I think we're doing a pretty good job right now. The number of clients who are undetectable is about 90%. And just at the last staff meeting, we usually set ourselves a goal, and the goal has been 90%, and we've met that for the past year. So we've changed our goal in the clinic to 95%. So hopefully in the next year we can do better. So that's a little bit about CARE and what we do. And I think my feeling is that I talked about the treatment cascade, so we'll kind of go in order from prevention to testing to linkage. Skip over treatment because I just talked about that, and then talk about some of the wraparound services, and maybe we can hear about how people, what your experience has been with that through that continuum. So thank you.
Okay. Hi, I'm Jalen again, just so y'all know. And I work more in the prevention side of HIV because I work at Cal State Long Beach as a health educator, specifically working with young Black MSM who are negative. I do have some positive clients, but we talk about different things with them. And kind of like how Michael had mentioned, the landscape of prevention has changed dramatically since like the 70s and 80s. Because when HIV was first coming out, it was just thought of it was a white gay male disease in a sense, so condoms was the answer. Then when you found other modes of transmissions, it turned to bleach kits for needles and various harm reduction techniques to prevent HIV being contracted amongst people who inject drugs. Then when it kind of saw more communities, you were targeting sex workers with more condoms and other different techniques. But then kind of as some populations started to decrease with new HIV infections, other communities started to see an increase, specifically amongst like Black and brown MSM. Especially in the past probably like 15, 20 years, that has been probably the most hard-hit communities here in the United States, especially here in LA County and Long Beach specifically. With last year, or 2016, about 30% of new infections came amongst Black MSM when they only make up about maybe 1% of the population here in Long Beach. So clearly there's need for some help in that community, and that's where kind of I come in. And mainly when I work with people in the community, it's a lot of talking about condom use, and hopefully we can get to PrEP, because sadly for a lot of young people in the community, PrEP can seem like it's out of reach, because when they hear about PrEP and they hear about you kind of have to go through the medical field to get it, if they don't have insurance, that's going to be the first thing that's going to kind of turn them off from thinking about getting on PrEP if they don't have insurance, or when they do try to talk about it with their doctors are uneducated about it. So that's going to be another barrier to get them onto PrEP. So I focus more on the condom use because that's kind of seem where they're more comfortable with, and maybe I can get some leeway and try to promote that amongst them. And also, we also talk a lot about testing because testing rates amongst Black and brown MSM specifically is pretty low. So we try to get people tested about like 3 times a year, depending on how many partners you have. If you're in a quote-unquote committed relationship where you perceive it to be monogamous, but your other partner doesn't perceive it to be monogamous, you should probably get tested more often than once a year. But some people don't see it that way, and so you kind of have to work with them on that line and trying to understand, like, just because you perceive things one way doesn't mean that's the reality of it. So I focus a lot about condom use right now as the main prevention tool, but PrEP pretty much is the new amazing thing out there because it's a pill a day you can take, prevent HIV, I think 95% or 95 or 97% prevention rate for that. And then also for people who have had recent exposures or perceived recent exposures, you have PEP, which you can take within 72 hours, which is basically just as efficacious as PrEP. And it's the same medication, but just taking it post-exposure rather than pre-exposure. But again, some people just really don't want to go through that route. And that's kind of sad, but especially in like Black and brown communities, there's a lot of medical mistrust that you also have to navigate with trying to promote that. And so it's hard to deal with that a lot of times because I can only do so much to try to help break down those barriers with the medical field. So condoms use is probably the major way, but trying to increase awareness about PrEP is one of the major things we do in the community. And also about condoms, there's condoms in the back if anybody needs condoms. So please feel free to take them. If you don't feel like you need them, somebody you know might need them. So feel free to take them. They're good till 2022. So use them. But yeah, that's kind of my spiel about like what I do in prevention. But when I've been working with young Black MSM for the past 2 years, kind of, I don't mean to say like they kind of play down HIV, but HIV isn't necessarily the biggest thing in their world nowadays. You know, us on this panel, we probably see HIV as probably a major thing in people's lives to worry about. But sadly, especially for a lot of Black and brown MSM, life is not the major thing in your life. If you have insecure housing or you don't know where your next meal is coming from, that's going to take priority in your life. You're not really concerned about HIV in this very moment, and that's very real for people's lives. And so when talking about HIV, you can't always talk about it in a sense of, well, you're bad because you're not thinking of it as being important. You kind of have to work around everything else that's going on in these lives, and you kind of have to tailor what you talk about and what prevention method you're going to talk about with every individual person you work with, because everybody is extremely different. Just because we're all kind of in the same community, kind of experiencing and walking through the same life, doesn't mean we have the same viewpoints, and not everything's going to work for everyone at the end of the day. And that's kind of been definitely true for my experience here working in HIV, is that everybody's completely different. And since I do work with students on campus, you would think they would be a little bit more educated and a little bit more open to things about HIV and learning more about prevention tactics. And sad to say that they are probably the hardest ones to work with at times because they feel like they're educated, they know everything, but when you tell them that you don't know everything, you kind of get some fight back. It's a lot of times that I see people who kind of I meet on the street or at bars or something, they're a little bit more open to the conversation rather than students. And so it's always an interesting experience working with students to try to break down their barriers and kind of understand that we're all here learning new things. Things change every couple of years. And so you kind of keep it like updated information, and working with them is just, it's lovely to say the least. So I've definitely had a lot of fun times with these past 2 years working in HIV. I've been lucky to see that none of my patients have tested positive throughout the program period. But working with a few of the few HIV positive patients that I do work with, just kind of pushing it more towards the U=U campaign like Michael mentioned earlier, because I think it was last year where the CDC and like World Health Organization finally kind of confirmed that because of the partner studies that have been going on for the past decade or so, we can kind of finally say that if you are undetectable and have a viral load, which like under 200 or 400-ish, don't quote me on that, but if you go on the websites, you'll see the exact numbers, you're unable to transmit HIV to someone else. And so trying to get them to understand that, because a lot of times HIV positive people can feel some sort of stigma when trying to have sex with someone else or someone else who is negative or of unknown status. And so trying to break down that stigma with some people, because if you've been living with this for a couple years and feeling like every time you have sex you could potentially pass it on, that could be kind of damaging to your psyche and how you feel about trying to navigate relationships in the future, and trying to get people to understand that because you are undetectable, you are staying on treatment, you won't be able to pass it on to someone else. And that's kind of a motivating factor to taking medication, and trying to get that and use that as a motivation for them to stay on medication, stay in treatment, keep on the right track in a sense, because that's what's necessary to kind of live in a healthy life and kind of go with the normal path of what we kind of say people's lives should look like when it comes to relationships, you know. That was kind of a quick little thing about intervention, but when we get to the panel discussion, feel free to ask more about any personal experiences and stuff like that.
All right, I'm not going to get up because I'm comfortable here. Hi, good morning, everybody. Thanks again for being here. My name is Ish Salamanca. I'm the Director of Health Services at the LGBTQ Center in Long Beach. And I'm going to be talking about the second column, which is pretty much testing. Or is it the first column? Well, anyways, I'm talking about testing. And we're talking about stigma today related to HIV. And stigma really does go across all aspects of this cascade. And when it comes to testing, a lot of people feel intimidated to come in. It's like, why do you need to go in? I am not a slut. I am not having sex with multiple people. I'm not a bottom. There's so many things that people think in terms of a stereotype of why not to get tested. I've done testing in all sorts of aspects. We've done mobile trucks in the past. I've done small community clinics. Now I run my own clinic here in a community center. And I've heard a lot of stories. One of the stories that I heard that's related to stigma is the mobile units. I've heard Black communities mention that they think that mobile trucks spread HIV because they go into a mobile truck, you come out and you're HIV positive. So they'll stop getting tested in mobile trucks because they've heard throughout the grapevine that that is actually spreading the virus versus stopping it. We can go back all the way to Tuskegee, where people were actually used in the syphilis study. So yeah, there is truth to that stigma. So us as providers have to work against that and kind of build that trust in our communities. When we talk about sex, no one really talks about sex anymore. We don't talk about bottoming. We don't talk about fisting. We don't talk about breeding. Like, we don't talk about things in detail when it comes to that. So when people start thinking, well, I don't need to because we don't talk about it, I'm not going to go sit in a room with a stranger to talk about why I need to get tested. So at the center, we test about 2,000 people a year, and we kind of diagnose anywhere from 30 to 50 people with HIV. So that's specific to HIV. We do STI testing as well, and about 1 in 4 people who get tested come back with an STD, whether it's gonorrhea, chlamydia, or syphilis. So to give you an idea, this is 20 minutes of your time where we collect the sample, and our jobs, and it's not just me, I have a team of about 5 of us, need to, in 20 minutes, gain your trust, build a rapport, and get into the questions about what are you doing right now that led you to get tested, and how do we keep you negative, or how do we link you to care if you're positive? It's really quick. When I first started doing this, it took about a week to get results back, and before that, it took about 2 weeks to get results back. So there's a lot of quick movement that needs to happen when it comes to HIV testing. We recommend people to get tested at least once a year, but the more active you are, the more you should get tested. It's a free service. You can come every month, every 2 months, as regularly as you want. But what we're noticing now is that, like Jalen had mentioned, HIV isn't necessarily on the top of people's lists. People think, well, no, I don't have HIV. I don't do this, this, or that. I need to worry about other things. So that now has become our approach to testing, where it's no longer who are you having sex with, are you using a condom, do you need condoms? Now it's become where do you live, how are you feeling mentally? A lot of people feel depressed. Self-esteem issues is a huge draw when it comes to unprotected sex or sex without a condom, where I've heard stories where people don't feel like if they ask a person to use a condom during sex that they're going to continue this relationship. I've heard stories where people will say, well, you need to put a condom on in order for us to have sex. And the person says, well, I don't want to. As opposed to saying bye, they'll have sex with them because they don't think that they're going to have sex or have a relationship with this person. I've seen other individuals who, especially women of color, I will ask them, why don't you have this guy wear a condom? It's like, well, he's going to think I'm dirty. He's going to think that I sleep around with other people. He's going to think that yada. And then the list builds because there's this stigma that when we talk about sex, when we talk about using condoms, that it means something else. I'll go to the guys and be like, why don't you wear a condom? Well, I don't need to. I only have sex with her. She's not going to pass it to me. I'm the inserter. There's so many stories that I hear that our jobs now have become more difficult to not just stop HIV or stop STD tests or stop STDs from spreading. It's now trying to stop that stigma of like, wear a condom, it's not a big deal, or come in and get tested. We have very few people who come in with their partners, and I love it when they take my advice, when they'll like come in with someone who's like, we're gonna have sex, but we're gonna get tested first, just like you told me. But that's one out of like 2,000 people that come in and listen to my advice. But the other part, I always try to get into their heads. I was like, the next time you decide to have sex, I want you to picture this and the conversation we had, because do you want to get exposed to something? Do you want to go into something blindly? And my job in testing and the job that I'd like to pass on to my staff is have a genuine conversation. Start using words like fuck and pussy and cock so it becomes comfortable, because a lot of, and I can speak personally for the Latino community, we don't talk about that. We do not talk about those conversations. My mom is 60, dating a 23-year-old right now. God bless her. Like, she has the energy to do it. I can't stand 23-year-olds. But I have been able to now have that conversation with my mom. It's like, you need to get tested. You need to test for STIs. You need to do all these conversations. And it's because of my job that I'm that comfortable doing it. If we go back in time to 20 years when she was having the conversation with me, she was not having it. All she was having, it's like, don't have sex. That was the answer. Don't have sex. So there's a lot of stuff that happens with stigma and HIV testing that my job now has become, how do I normalize it? How do I make this fun? How do I make this part of a routine test? Which kind of leads me now to STI testing, which we do now. People seem a lot more comfortable to want to give me blood, give me urine to test for things that are treatable. So I'll just throw in an HIV test there to make it normal again. But now in there lies another issue that I'm noticing, is that people are getting STDs a lot faster than they recognize, that they realize. 1 in 4 people have rectal chlamydia. 1 in 3 people have rectal gonorrhea. And does anyone have an idea why those two match when we're talking about HIV and STDs, like what the connection is? So pretty much HIV lives and thrives off of your white blood cells. That's what it duplicates to replicate itself and spread through your body. What happens when a person gets an infection? When a person gets an infection in your body automatically makes white blood cells. So if you have gonorrhea, your body's thinking, we need to stop this gonorrhea, let's make some more white blood cells and fix that. Now let's say that your sex partner also has HIV. With so many white blood cells in there, you're actually increasing your chances of getting HIV potentially, because your body is living with a current STD. So a lot of people think, no, I'm good with HIV. Don't worry about it, we'll just do the STD tests. I need to start talking about having those. So doing routine STI testing is important. The other part is 3-site testing. A lot of times if you go to your doctor, they'll say, you want to test for gonorrhea and chlamydia? Here's a cup, go pee on it. I don't know about you, but I use most of my body when it comes to sex. I don't just use one part of it. So your throat, your rectum, your vagina. A lot of times people with vaginas will pee in a cup, but your urethra is nowhere close to where your cervix is, where most of the penises go. So if you pee, most likely you're not going to catch something. You need to do a cervical swab and get up in there. So a lot of these people think, oh, the doctor did a swab, or I went to go do my pap smear. It worked. unless you're looking for specific areas, you don't know that you have something, which creates this cycle, which I'm just learning in the last few years, that is what's leading this epidemic right now, where people think, oh, yeah, I'm fine. I got tested. I peed in a cup. I'm good. But that person has it in their throat. And then they'll go give oral sex to their next person. Now they have it on their penis. And then that person has sex with someone anally. So you see the cycle, right? And everyone in that group has gotten tested. The drawback is that they're just peeing in a cup. They're not testing in the size that they need, which goes to what Michael was saying, where providers nowadays need to get educated. So my job in testing has now been like, I can't carry the burden of the city of Long Beach and doing 3-site testing by myself. I need to get everyone to start doing it. So one of the things that I ask every time that I speak to people is the next time you go to your doctor and your doctor says pee in a cup, if you have the courage to be an advocate for your own sexual health, ask them to swab you. Even if you don't use your throat, even if you don't use your butt, put them in that place where you're asking them to swab you, because they're going to ask you why. And then you let them know, I want to make sure that I'm clear of STDs in all 3 areas that I may or may not use. And the doctor will look confused, just as he looked confused when he asked me about it. And he'll do research, or she'll do research, and then that starts going. But when it comes to testing, I need all y'all to either, one, get tested, learn the experience, share the experience. And if you've been tested, tell other people that, how are you getting tested? Is it your rapid HIV test? Did you get swabbed in your butt? Did you get swabbed in your cervix? And start using these conversations very upfront. Because one of the things I think that the reasons we're here is the stigma. No one's talking about this. There's a lot of fear behind this, because when was the last time that you talked to someone about your sex life? I had that conversation on my Uber ride here with my driver. I was like, I want to see this whole stigma thing and see if it's actually true. And I was like, hey, when was the last time you got tested? He's like, why are you asking? I'm getting ready for a conversation that I'm having with a group of people. And he was like, I don't get tested. I don't need to. Why? I'm straight. There you go. You see that stigma there that you think, oh, well, only gay people need to get tested. So anyways, next time, anyone you're talking to, even your coffee maker at Starbucks, ask them about getting tested. Have that conversation and then tell somebody else. And that way we can spread the conversation versus spreading the virus and hopefully stop it. Well, anyways, if you have any questions, I'm sure we'll get to that point at one point.
Hi, everyone. Can you hear me? Oh, there we go. So, my name is Tanu Oma'aleo Nelson Ayu. I go by Tier Tanu, and I'm the founder of Project Alofa, which is a civil rights grassroots organization that advocates for formerly incarcerated. So I'm going to be talking a little bit about barriers. So 2 years ago, I was invited by the Wall Las Memorias to participate in a study for PrEP. And so I went to Olympia Medical Center to participate in that study and found out that I had hepatitis B. So I was disqualified for that study. But from that day on, I was taking Truvada for my hepatitis B load, but I was also very active with a partner who was HIV positive. So it was kind of a win-win situation for me. But at that point, at that day, I said, you know what, I need to begin to be a voice in my community, because he shared with me that hepatitis B runs rapid with my Pacific Islander communities. And so I decided to work with our organization and our Native Hawaiian Pacific Islander communities in creating access to PrEP and also educating on something that we never, ever speak about. Within the Asian Pacific Islander community in 2014, there was a 17% increase year over year with the infection with HIV. So it was really important for me to highlight that at Pacifica Pride last year here at Long Beach City College, and to share some of the difficulties and challenges with access to PrEP. And not only that, but also to kind of destigmatize getting tested, like Ish just shared. For many of us, they didn't even want to go into the truck or be seen going into the truck or an institution or agency that was testing. So last year at Pacifica Pride, we black curtained a whole portion of Long Beach City College, so people weren't aware of you going in to get tested. And that's the stigma too about our Pacific Islander communities. When I spoke with our interfaith leaders, the first thing that they said was, well, we don't want you to begin to talk. Let our youth leaders begin to speak. And so I saw there that there was really an opportunity for us to really educate, because they were very misinformed. You know, they were still thinking if you drank from my cup, right, that you would get HIV. And this was from our tinas and our tamas, our faith leaders who were spreading this around, saying, don't. You can get HIV if you drink or eat from his plate. And it was really important for me to dispel that. And that's why it was very intentional to invite them to Pacifica Pride last year, where we had Micronesian, Melanesian, and Polynesian leaders who were educated on the basics of HIV 101, but more importantly, how to access these services. And we see now that there's a need, definitely a need in North Long Beach, where we have a high concentration of Pacific Islander communities. And right now there's a lot of sex work happening in North Long Beach. And it includes our Asian Pacific Islander transgender, young youth transgenders who are working there. So I also facilitate, I'm the program coordinator for Los Angeles Center for Alcohol and Drug Abuse. And we just opened up a site there in North Long Beach. And we talk about access. And I see them every day because they sleep outside of my agency. They recharge outside of my agency. And our agency is kind of like being known as the safe hub. I don't chase them away. But we were very fortunate most recently to partner with UCLA. And I know we are bringing the ATN program to our agency because there's a need for services in North Long Beach, but more importantly, there's a need for people to support people, to speak about it. And I know ATN is going to be at the center as well. They're at the center. And so now that we have one at the center and one in North Long Beach, I'm really excited about this because this begins conversations, right? This begins to break out of the mold, right? Ish is talking about using words like fuck, cock, pussy, right? We go beyond that where we're at. Like they're beyond fisting and, you know, cum dumping, whatever you else want to talk about. But Joel and the center is bringing that conversation with youth from Jordan High School to our agency. So we're beginning this conversation at our agency at a young age, and ATN is also targeting our youth 12 years old and up. But more importantly, we begin to now have access. We begin to now provide these spaces to initiate conversations and peer support. And for me, as somebody who has been formerly incarcerated, I know 12 felonies and so many redemption of my points at Twin Towers that I have been in 9,000, 5,000 floor where over half of us are infected with HIV. And so we have a unique program in Twin Towers where we distribute condoms twice a week to our inmates. Even though there's a red sign on there that says engaging in sex will give you a 288 sex offense, they understand that we're still going to have sex in jail. And so one of the reasons I also advocate for that too is because a very dear unicorn friend of mine was infected and contracted HIV by having sex inside there. Went in and this unicorn was negative and came out positive. So we know that we have a lot of work to do, especially even our Pacific Islander men coming out of jail, coming out of prisons. They've had sex with men, and they're coming out into our communities and not sharing with their partners that they are infected. And that's the truth. We have our lifers who are coming out on sensitive needs yards, right? And they have been engaging with sex with men inside prison. They don't want to speak about it, but we now have a group at LA CADA that supports formerly incarcerated men on the down low. So these are the things, these are the barriers that people don't want to talk about, but these are efforts that we are intentionally making so that we are reaching communities to prevent this. And we talked about, I think a year ago with Mark McMillan saying that we had the highest rate in Long Beach, the city of Long Beach, with HIV, the prevalence rate with HIV in Long Beach. And the Native Hawaiian Pacific Islanders was the fastest growing demographic, Asian Pacific Islanders and Native Hawaiian Pacific Islanders. And of course, being incarcerated with that down low was part of the reason as well. And so we know we have to make every effort to destigmatize with our communities who have been formerly incarcerated, as well as our faith leaders, as well as our youth, to come together. So at the center on Tuesday nights, we have an intergenerational Pacifica Pride support group that educates, stimulates, and also allows anything under the umbrella to be talked about. So if you want to talk about that you just got fisted or whatever else, yeah, we can talk about that. If you went to the bathhouse, I'm just saying. If you went to the bathhouse and you just had a weekend of party and play, then come over there. But this is what we need today. We need to break outside of the shell. We need to be intentional with opening spaces for courageous conversations. And that's how we destigmatize in our communities. If you're ashamed because you just got a blowjob from Tom, Dick, and Harry, Mary, Jane, and Sue, then guess what? You need to come to Tuesday nights at the LGBT Center so that we can process that with you. That you need to begin to speak about things. You need to begin to be courageous in sharing with people what services are out there. And that was my duty. And I'm sweating like a pig because I'm a little nervous, but I'm very, very, very adamant about being a voice in my Asian Pacific Islander, Native Hawaiian Pacific Islander community, because I see who's tokenized in PrEP campaigns. It's my transgender Pacific Islander who's on these PrEP campaigns. But we need to have PrEP campaigns that people that look like me and you, right? We need to have campaigns that go out there and speak and showcase the regular. Because if we continue to have campaigns that are just your flamboyant person or your transgender woman, we're not doing our jobs. A good percentage of who's being infected and who is infecting are the ones that aren't getting tested and the ones that need to come out and share. And some of these barriers are just shame, guilt, right, and fear. And being an SUD counselor, I hear it all the time. I hear it all the time. The reason why they want to go out for some of my community members, they just want to go out and have sex one more time. Just want to go out. Just want to go out and hit it one more time. And sex takes them out all the time. So we're very intentional. If you're going to go and have sex, take your medication, take some condoms, take some lube, and go. But make sure you have your medication with you. We can't control that, but that's part of our harm reduction. If you really are adamant that you want to go out there and use again, take your medication with you. Because the first thing that goes is you don't care about nothing. You're not going to be taking your medication. You're not going to be having safe sex. We're like, okay, go ahead. Have one more run, but at least take your medicine with you. But these are some of the barriers. I talked about access, I talked about stigma, but also those of us who are engaging actively, right, in multiple partners, I think we need to begin to start surfacing that these are activities that are normalized. Like, I admit, I'm a hoe. Like, I go out and I don't have a one-person relationship, but at least I speak about it, you know? I'm very honest. A lot of us sit here and we're like, I don't know. Girl, I can clock your tea in a heartbeat. But it's important that you begin this conversation because this is the only way we're going to destigmatize. So have these bold and courageous conversations and build a new unicorn.
Can everybody hear me? Okay. My name is Nolan Ross Samewal, and I'm a community advocate, and I'm here to share my experience with the continuum of care, as well as my experience in getting infected, and how the stigma related to my own personal story, and how it kept me in my disease, not just of being diagnosed with AIDS, but also with alcoholism and addiction as well. First and foremost, thank you, Professor Madavi, for allowing us to be here and to speak to your students. Thank you to everybody on the panel for being here. It's awesome. I got to meet a lot of great people throughout this process, and continue to have those relationships is great. So thank you. So my journey, as you can tell, I'm Asian Pacific Islander. I grew up in a typical Filipino family. My mother is a nurse, and my dad's a computer engineer. We grew up in a typical family, in North Downey. So we had we had everything that we needed. Growing up, I had everything that I wanted. I was kind of spoiled. And there always was this whole stigma just about emotions in my family. If you were sad or if you were angry or anything, you didn't really go to your parents for a hug. You know what I mean? Having them tell you they love you is kind of not there all the time, especially the physical, like hugging you and kissing you and stuff like that. So growing up, we learned to be what they thought was independent and a strong person. So growing up, towards like middle school, I remember myself feeling a little bit different, as a lot of us do. I've had feelings for the same sex about my seventh grade, and I remember at that moment, it's funny because I remember having feeling towards this. It was a drummer in band, and I was like, oh, and I remember just looking, and I was like, and I had like my heart started beating. I started feeling, having butterflies, and then I also knew that it was also like my heart dropped at the same time, because I knew as soon as my parents would find out that they wouldn't accept it, that I would be shunned by my family, and that really hit hard for me, because going home that night for about a week, I cried every night. And I prayed to God to change who I was. You know what I mean? I just knew it. I knew that they would hate it. So instant shame, and this wasn't coming from wasn't coming from my environment, but just coming from the stigma of what I thought my parents would feel towards me, And I started learning how to keep secrets. So as I grew up, and I had my first relationship with my partner at that time, I learned how to keep that secret. We had letters that we write to each other, love notes. And one day, my mom called me into her room, and she said, "Can I ask you a question?" And I go, "Oh no, this is it, And she goes, "Are you gay?" And I go, "Well, if I said yes, would you still love me?" That was my question to her, and she said yes. She paused and she said yes. So I thought everything was good. For about a week, I still felt like a looming cloud over my family. And then after about a week, I came home. I think I was working at In-N-Out at that time, But I came home, and then I just remember her pressed up against the wall in my sister's room, crying hysterically. And my sister was trying to console her. She kicked my dad off of her. He fell on the floor, and he's like, "Look what you've done." So, yeah. She was like, "Look what you've done. Like, what am I supposed to do?" Up until that point, me and my mom were very close. Very close. We'd do everything together. I lay in her lap, what I mean? Sometimes I'd sleep with her in her bed. And then at that moment, even until 17, I would just like want to be by my mom. Even until that moment, at that moment, my life changed. It was 180 degrees. My mom did not speak to me. My mom did not speak to me. And I remember after that moment, like I was in my room, and maybe this was about a week's past, and I was crying, and I was rocking myself in front of the TV, not really watching the TV, but just crying, rocking myself. And then my mom's standing at the door, staring at me with her arms crossed, and just looked at me for a couple minutes and just walked away. That was tough. That was really tough. So, yeah, as time went on, like I learned how to, I just learned how to try to live. I just tried to live life without my parents. I was running. I was already running at that point. I was trying to keep secrets. You know, I stopped. I stopped. You know, I broke up with my ex. All my friends who identified as LGBTQ, I stopped talking to them. I tried to be the person that my parents wanted me to be. I was sent to conversion therapy. That did not work. You know, that did not work, but it was tough. So I started to lie, and I said I had to work, and I was hanging out with people that were probably not the best positive role models for me, but they were the only people that was there. At that time, I started experimenting with alcohol, which progressed to drugs, specifically methamphetamine, and when I used methamphetamine, like it started off, you know, with a hookup, and it never stopped. So the only way that I could find any type of like happiness or quote unquote happiness or any type of quote unquote like joy in my life at that time was to use drugs, have sex, and you know, find other alternatives than to be at home. You know, be at home with my family. I remember one day, you know, after several years of my mom not talking to me, you know, like, she told me, she's like, one day, she's like, you know, by the age of 30, you're going to have HIV. That's the only thing she said. And I remember looking at her, and I was like, speechless. And I was like, that's all you have to tell me after all these years, you know? So a couple years passed by, and at age 29, I was diagnosed with AIDS. So I'm 35 now. So probably that was what, like 6 years ago? So 2012. And I remember in April of 2012, I started losing weight. As much as I was eating, I started losing weight. I'm usually about 160 pounds. I don't look like that now because I'm on Weight Watchers, but you know, you know, and it's working. You know, like so back then, you know, I was usually 160 pounds, and I started progressively losing weight. In April of 2012, I was wasting already. That means like, you know, you just start losing weight. My throat started hurting tremendously. I started getting black lesions all over my body, which is Kaposi sarcoma. I had candida, I had thrush, and I had pneumocystis pneumonia, so microorganisms living in your lungs. And I remember my you know, like my aunts coming, you know, and they knew that I was being stubborn, and I was very afraid because, as we mentioned during the introduction, I used to work for AIDS prevention, and at that moment, you know, when you're in your addiction and when you're in, you know, your active using, you don't care, you know what I mean? I knew what was going on, but I didn't want to know what's going on. I was afraid about my family. I was running. Who am I going to stay with? Where am I going to go? You know what I mean? Although I was living under their roof, I was like I was not even there. I was like a ghost already. I became bedridden. So I was bedridden from maybe like May to like July, still using drugs, still running. My family came to visit me. Do you need help? You want to go to the clinic? You know, things like that. And I still said no. And it wasn't until the very last minute, you know what I mean, the very last minute where like I couldn't breathe. I just couldn't breathe. Standing up and going to the restroom was tough. You know, I mean, I was fainting. I fainted, and you know, the lesions got darker. My skin was being raised on my face. And in 2012, I barely could walk. I entered that clinic, and paramedics took me out and took me to Martin Luther King, and well, again, my whole world turned upside down again. Talk about being lost already. Being at Martin Luther King, not having insurance, being on Medi-Cal, getting emergency Medi-Cal was just a whole different thing for me. I mean, I thought I knew stuff. You know what I mean? I thought, you know, I consider myself, you know, educated. You know what I mean? But at that moment, you know, I thought I knew how like the whole like continuum of care worked, all that stuff. But I was thrown to the wall. I had no idea. I had social workers assigned to me. You know, I was in a wheelchair. Leaving that hospital, I couldn't walk anymore. Standing up wasn't even, I couldn't even walk. I was at about I'm 162 pounds, so I was about 107 pounds. I had no muscle, so I couldn't even walk. And at that moment, you think, like, all right, well, maybe I should change the way I am, change the way that I live my life. But the shame and guilt was so strong at an early age, and it carried on, and it manifested itself into drugs and alcohol, manifested itself into HIV and AIDS diagnosis, and then it continued on. It wasn't addressed. So when I got out of Martin Luther King, I still had all that ailment, that's mental and spiritual ailment. So my mom stayed with me for a couple months after she took some time off, and she actually nursed me back to health. And I still had such a deep resentment at that time that, as soon as I was able to get up and start driving, my ass was off and running again. First thing I did when I could drive was go pick up some more dope and get back into my disease, and then just go from there. Like, I remember thinking to myself, I can't fix any of this. There's nothing I can do that's going to change this. Nothing that's going to do to make my parents really love me. Because even though she stayed with me for like 2 months, I don't really think she loves me, So it took me off and running, and I think by the grace of God, there was some type of intervention later down the line with who is my husband today, asked me to go to meetings. And I entered rehab, and I had to go through rehab 3 times. The first time that I went through rehab, I had no idea why I was there. I was like, why am I here? You know what I mean? I went to an indigent rehab right here in Long Beach called Redgate. I don't know if anybody's familiar. So I went there the first time. I was there for 56 days. Going in there, I remember trying to do everything perfect. I was their golden child in rehab. How do you become a golden child in rehab, right? But I never had any, I didn't get in trouble. I didn't do anything like that. But really, that was just another manifestation of my disease. I didn't want to feel any emotion. I didn't want to get in trouble because I didn't know how to deal with trouble, being in trouble. I didn't know how to deal with being in fear. You know what I mean? So I tried to do everything perfect so that nobody had anything bad to say about me. So leaving there, that didn't help. I mean, like, it opened my eyes to seeing the community, to seeing that part of the community that's dealing with this, but I really didn't know why I was there. I didn't identify. Second time I went through the Gary House in Orange County, and I was there for 90 days. The Gary House is a treatment center that's specifically for HIV and AIDS, as well as people who are IV drug users. So I went there. I stayed there for 90 days, and I found out that I was codependent. A lot of this shame and guilt was derived because of a lot of codependency. If somebody jumped, I jumped. I didn't have any self-worth. I didn't know how to love myself. Somebody smoked cigarettes, I decided to smoke cigarettes too, So somebody went out who was my first friend at that center, and then I was like, well, if he can't do it, I can't do it, and I went out too. I entered rehab one last time, went back to Redgate, and this time I lost everything. I lost the support of my family. I lost my job. I lost my partner. I lost everything. The only thing I really had was a car, and that was it. And then, so I went in there. I did it for myself this time, and I did it. I stayed there for 4 months, and I took things very slowly. My HIV and AIDS was at that time already manageable, because since, as much as I probably missed, there was times when I missed my medication, but for the most part, I was pretty good with it because I knew that was something extremely important, that I had to take it. So it was manageable, but, I can't forget the reason, lots of the reasons how I got it, And so I went through this rehab this last time. I stayed there for 4 months. I took things very slowly. I volunteered at the treatment center at Redgate for 7 months. And afterwards, while staying in sober living across the street, I got my dollar meal in the morning, my dollar meal at lunch, my dollar meal at dinner time, and I found myself pursuing a life in working in treatment. And now I work at the Anaheim Lighthouse. I am the alumni outreach representative there, and we help a lot of people who are dealing not just with addiction and alcoholism, but there are also people in our communities too that who are struggling with HIV and AIDS, and not many people relate. So I'm glad that I'm somebody that can be there compassionately, with empathy, and to tell them a little bit about my journey. I'm a little over 2.5 years clean now, so I'm sober now. That's great. This is good. Thank you. I consider myself a survivor, a community advocate, and if there's any way that I can help with any type of situations, but especially HIV and AIDS, I'm all for it. So that's my story. Thank you for letting me share.
So I'm thinking that for the sake of time, if there are any questions, maybe we can take questions. But one of the does this work or not? We can have one mic for questions, Jessica, if you don't mind to maybe take one mic around, and then one mic maybe the panel can share. So maybe at this point we can open up to the question.
Yeah, you need the mic for the camera. Yeah, what I did is,
This should be. It should be green on top. If not, I can still hear you if it doesn't work.
Yeah, let's go. Yeah, I did a report on HIV and men on the down low. And what I came up with, it was a lot of the youth that was getting affected. Are you doing anything to address that with the youth?
I don't work with people under the age of 18, sadly, only because I'm not allowed to work with people under the age of 18, at least officially. But I work with 18 to 24-year-olds, so it's basically young adults, people who are hopefully, or not, I wouldn't say hopefully, but most people who are kind of starting their sexual career during that time period. And it's definitely a lot of working with young black MSM, and sometimes who don't necessarily identify as gay might identify as being on the down low or something like that. So basically, we just try to talk about kind of using condoms, potentially PrEP, possibly PEP if it needed, and potentially, and then also talking to your partners about sex. So I definitely do work with a lot of young black MSM in the community here in Long Beach, and then also in like the Carson area as well. I see a lot of young black MSM who are kind of starting out who don't know anything because, again, like in the black community, we don't talk about just gay issues in general is what's the big no-no in like many black communities. So I do work with them and try to get them to talk about sex and not necessarily identify with being gay or with the community, but talk about, like, if you're going to have sex with men, this is what you got to do. This is how you kind of navigate, all that kind of stuff. And it's kind of sad that in this community we do have a lot of infections, because if we kind of stay on the track right now, 1 in 2 black MSM will be infected with HIV at some point in time in their lifetime, which is kind of on the lines with, I think, sub-Saharan Africa HIV rates, which is kind of crazy to think about in the United States, where we like to think we're progressive.
We also have a program, the ATN program that's at our center, at our agency, and at the Gay and Lesbian Center, and it's the adolescent testing network, and so it's from 12 through, I think, 24, 12 through 24. So there's opportunities if you know of anyone that wants to be there.
Yeah, and then one of the things we do at the center is we have a Mighty program. It's mentoring youth through empowerment, and we go through all the schools. We focus on Long Beach Unified, but we don't just talk about sex. We don't just talk about HIV prevention. We talk about gender expression. We talk about sexuality, where we give people different options. Because I think what happens with people who identify in the down low are because they don't feel like there are options. So we talk about gender fluidity, sexual fluidity, where you don't necessarily have to identify as gay or bisexual, where like we talk about it in a more fluid sense. So we're starting to see a lot of kids who identify as queer. They're taking that word themselves now, where it's not necessarily gay or straight, it's just different. We're trying to, with that program, trying to plant that seed where you don't necessarily have to pick at that age, which I think in our generations have kind of let that, where it's like, okay, well, I'm not gay, I'm not straight, So I'm just going to keep it on a secret. And I think we're trying to have those conversations through either the Gay Straight Alliances, GSAs, or any kind of club that will allow us to have that conversation. But we try to have that side of the conversation where you don't have to pick and you don't have to be ashamed if you're not something else. But I think it's a collective of different kind of conversations.
I think this question is for all of you guys. I work for Safe Refuge. I work for Safe Refuge, and then we have had, like yesterday, we had someone from the care clinic coming to talk to us about PrEP and all that. And after that, what I realized was that 90% of the staff, even the senior staff, didn't know anything about PrEP or PEP. We talked about it the whole day. But this is just staff. And then you work in a treatment center, you have to do the curriculum, and that's all you do. This is not the people that really need the information to know about PrEP. It doesn't mean that if you come and teach the staff about PrEP, it's going to go to the clients. Because I will teach the curriculum, nothing else about the curriculum. Is there anything that can be done from your agency is that you can target the clients? Because me knowing about the information doesn't help the client that I go in every day. I realized that I couldn't even give this wristband to the client. I have to seek permission to do that. So this information, even if it's there and then you come and teach us as staff members, it doesn't go down to the client. Is there anything that can be done maybe that can work with, if it comes from you, I can help with that and negotiate with the director and say, this is the code, but you get the feedback, the support from you guys so that you can reach the client. I wanted to bring a bus with the client, but I couldn't. But I went to we have to go to this person comes back to me, I will go to my boss comes back to me. I didn't bring the clients today. I wanted to. It looked like it was possible from the beginning, but I'm here by myself. So if you guys could help us, if there's anything you can do to help us.
So one of the biggest things that I always do, I never give answers, I never give advice, I always just pass it back to you. I save my agency like hundreds of thousands of dollars on marketing because I don't depend on having signs up or having conversations. I pretty much, everyone in this room now has some information, and your job now becomes to spread that information. So I would say if you can get 1 or 2 clients to listen and maybe participate into these or just have that conversation and have them talk about PrEP, I think that is the best way to get the message out, because I could sit down and tell you every benefit, backwards and forwards, of PEP and PrEP, but you're hearing it from a provider. You're hearing from someone that's negative. You're hearing it from someone who, whatever you think of me, it's not going to sit in. But if you tell another client who's in the same program, that message tends to sink in a little better. So my thing is, everyone in this room knows a little bit about it, or if you want to know a little bit about it, then share that information with your family, your coworkers, your clients, your roommates, and have that conversation. I think that's the best way. Because even I think if you would have brought them here, they probably would have fallen asleep. They probably would have gotten bored because they're just listening versus having a conversation about it. So I would say the best way, in my opinion, would be having them have that conversation. If someone's already on PrEP, send them out to talk to another room or another set of people and just having that conversation going. Because that's how we get our clients. We don't promote, we don't do anything. We just do a great job, and then those people tell everybody to come in and get tested. So I think that can apply to PrEP as well, where we just have a relationship with Michael where I don't necessarily need to just, here's a piece of paper, go meet this stranger. Like, they already know everybody because we all work together pretty much seamlessly. So I would say if you want to get that message out, just have people start talking.
I just wanted to add on to that. When talking to people, also pick non-queer identified people, because PrEP tends to be like a queer conversation or happen in LGBTQ plus spaces, and that leaves a lot of people outside the gap, especially with people who don't identify with the community, like Black and Brown MSM, who are afraid to identify as gay or don't want to identify as gay. We kind of have to be more strategic in educating people who aren't part of that identity to get the word out, because those are also people, like, especially in the black community, older black women tend to be trusted more by young black men. Educating people who kind of have trust in their identity already in the community, you know.
And then with our agency, LA CAUTA, we've been very intentional since we are working with the lead diversion program with the city prosecutor and Long Beach Police Department. So those who have been caught with sex work are now referred to our agency, where we provide the HIV counseling, the HIV education, and we're including PrEP as well into that case management. But more importantly, it's all about word of mouth, like our panel is saying, empower one, each one teach two.
Is there another question?
So once we begin to have these conversations, where can we direct? I know you mentioned the care center. Is that a Long Beach-based program, or is it nationally?
Here at Long Beach at St. Mary Medical Center? I think, I think this panel is a good example that I think anybody at this panel can refer to anybody at any other agency at this panel. We're all familiar with each other, with the work that we do. If I get a client, I'm sending them over to other people. And so we're a close community. So you don't need a specific point of entry, I think is the ultimate thing to say, that we're all interconnected in a pretty good way. So if somebody just accesses any services, they'll have that conversation and they'll get other stuff that they may need.
I mean, to echo, you pick what the person is most comfortable with. So you have Tanu, who's in North Long Beach, who works with a specific demographic. You have Cal State Long Beach, you have the hospital, you have the LGBT center. So with whoever you're talking to, you figure out where you're more comfortable and what are your specific needs. So that way, just like Michael said, the four of us can probably connect them to where they need at that point. But if they felt more comfortable talking to Tanu at the beginning, then Tanu can have that initial conversation. He could probably send them to me for, let's say, youth services. If they need to get tested, then I can send them over to get the PrEP study going with Michael. So it's just find that connection of where they would feel more comfortable. Because probably straight off the bat, if they don't want to come out as queer, they're not going to come to the center. They're going to be scared. But if they meet Tanu and he talks the talk that he does and makes me look good, then they'll come over because they know me. So just find that point and kind of get them in, because I think a lot of the mistakes that we do, it's like, oh, you want HIV testing? Here's my only one contact. I have no idea who's there. Versus just finding that connection, and then we can do the job.
Thank you so much for wonderful, great, informative talk that you had, and I think you taught me a lot. There was things that I didn't know, and I believe that every time that you hear something and you feel really uncomfortable, the job is well done. So if you felt uncomfortable today, that means that there are things that we need to know. And I really wish that this kind of education would start in high school with that transparency and straightforward talk, and so that we don't have to start at the older age. But until then, until those things that we wish for would happen, the job is this advocacy. The job is to be courageous and talk about everything that would be for the betterment of the society. Social justice is not selective. So there are some people that are very selective about certain population. But in my opinion, if you're for the betterment of the society, social justice means every population that is facing injustice needs to have advocates. Any injustice anywhere is injustice to all of us. So I hope that these kind of forums and talks will continue. Our hope is here with Long Beach City College Justice Scholars to have yearly symposiums for HIV and AIDS awareness. This was our first. We will do a better job next time, but we would love to have you back. So thank you again for everyone that attended, for the panel. Thank you so much. And if you want to stay afterwards and have a personal talk, you're more than welcome. Thank you.